acute respiratory distress syndrome. Since long it's there. It's not new. The issue with the COVID is the mortality. The ARDS before, it's coming actually around 35% of mortality. We have many causes. Maybe pancreatitis lead to, maybe surgery, maybe sepsis, maybe any type of amputation lead to ARDS. But with COVID, the mortality rate more than 75%. Most of them are died. Remember yesterday we were talking about something is called Berlin formula. Remember? And we are given the mild, moderate, and severe. And in case it's the VO2 is not available, we can divide the SpO2. Divide FiO2 should be more than less than 315 means suggest this patient has ARDS. Means the management for those patients will be what? Different. Okay. This is you need to memorize. No way. Or anyone he would like or she would like to be in the ICU, even HDU, it's important for you to memorize the initial setting for the mechanical ventilator. Yesterday we are talking about tidal volume, inspiratory pressure, target for us is important for the RDS all the time, more than 92. There is something for the tidal volume here. For example, since 10 years they are giving too much tidal volume, 10 liter and more. Nowadays, no, they are decreasing. The best between 6 to 8 for the COVID patient. The tidal volume again 6 to 8. For example, if the patient he has 70 kilogram, I will multiply by 8. After that, I will put the set in the mechanical ventilator by the doctors or respiratory therapists around 560 ml per kg. This is very, very important here. For the head injury patient, because we are receiving so many patients with head injury, we are keeping it around 4, not more than like that. Okay? Now, you know the respiratory rate should be between all the time between 12 to 16 to 18. It's fine. The minute volume, this is another formula. You have a lot of formulas for the respiratory system. And the IA ratio all the time we have less than expiration. The inspiration less than expiration. What does it mean? We need more and it will take very short expiration because we don't want that alveoli to do what? To shrink or to collapse. We are doing all the time that we need more inspiration more than expiration. This is very, very important to keep the alveoli is open. There is something little advanced, something is called lung protective ventilation. The most important as a nurse, you need to all the time continue monitoring spontaneous SpO2, monitor all the time the ABGs, and ABGs, it's a must to be in the ICUs. We can see here some areas, not in the hospital, outside, where there is ICU, but without ABGs. You can't work. Monitor ventilator parameters regularly. We have the parameter, this is the doctors and the others. And the new nurses, the critical care nurses today, they need to know, Karin, about this one, ventilator waveform. Not only the reading, how is the wave is important to make some correlation and information what's going on for the patient. Remember yesterday we mentioned the PEEP. The PEEP, the physiological PEEP is 5. To keep that alveoli is open. The problem with the PEEP is we have a lot of side effects. Hypotension due to decrease what? Venous return to the right side of the heart. Remember yesterday? Increase in the thoracic pressure, decrease in venous return. Finally, decrease in cardiac output and hypotension. Over-distension of the normal alveoli if possible. Ventilator-induced lung injury in the dead space. That over-distension in the alveoli lead to the paratrauma and volutrauma is important. Titrate the FiO2 is important here also. And the maximal PEEP level determined by the individual basis means between 10 to 15. Again, more PEEP, we have complications. There is advantage, at the same time, we have complications. Severe ARDS with the patient, maybe it's difficult to manage with lung protective strategy, yes. But maybe the patient with ARDS developing something is called refractory hypoxemia with severe acidosis. It's unable to achieve lung protective device or ventilation target successfully. The refractory hypoxemia is we are given too much oxygen, but the PaO2 in the ABGs, it's not increased more than 55 or 60. Okay? Recognize the patient early using what? Again, Perrine definition, and it's important here to avoid harmful ventilation. Then this is our target. What is the refractory hypoxemia? I keep it for you. Refractory hypoxemia is a condition with a patient unable to maintain partial pressure of oxygen in blood gases, PaO2, more than 60, despite providing 100% oxygen, even for a long time. Okay? Now, if the PaO2 divide FiO2 ratio less than 100, it's indicate refractory hypoxemia, means the patient has what? Acute or severe ARDS. Okay? Okay. What is the refractory? We have some explanation here. I will not go through. But the causes of refractory hypoxemia could be severe oxygenation, impairment for the patient with ARDS, or ALI means acute lung injury. Acute lung injury. It's also caused by ventilation-induced injury like pulmonary trauma. Cardiac disease could be also with shunting of the blood, could be making another cause for causes refractory hypoxemia. Okay. ARDS, my moderator, I will not go through that part. Now, respiratory complication because of the mechanical ventilator. What do you think? What is the mechanical ventilator problems? Because we are using the mechanical ventilator. What do you think? We have so many things, huh? For the ICU nurses, number one, we have packing or asynchrony. Means the patient is fighting with the mechanical ventilator. Okay, fighting. Maybe the patient is not sedated well. Maybe the patient also is, the sitting is not fine, and the patient, he has pain, or there is another problems. Autopeep means patient doesn't expire full tidal volume, and air becomes trapped. Can cause increased alveolar damage. Means trapped, means we have leak in the tidal volume. The patient not receive the full amount of tidal volume, lead to something is called what? PEEP, lead to, at the end, what you will do? Alveolar damage. Paratrauma, what does it mean? Damage the alveoli because of increased the pressure and the volume we are given for the patient. It's fine, the explanation, or what? Oh. Is it? What do you think? What video come to? Come big joking with me. Oh, come behind. Okay. Remember the terms. Number one is asynchrony. Autopeep, mention and explain what does it mean. Paratrauma and volotrauma. Autopeep, again, we have increased the alveolar damage. Paratrauma, damage the alveoli because of the increased pressure and the volume. We are the one putting that one because as we have advantage, but at the same time we have disadvantages. Muscle deconditioning or vent depend and ventilator associated pneumonia. This is one of the major issues in the ICU. What is the definition of the ventilator or the criteria for ventilation associated pneumonia? Let's start there, I mentioned. 48 hours after intubation. 48 hours. This is the one criteria. It's not come as normal pneumonia come from the beginning. After 48 hours after intubation. Other complications related to the mechanical ventilator. Number one, hemodynamic compromise. Hemodynamic compromise means the vital signs. We have a lot of problems regarding sometimes hypoxia, could be oxygen toxicity. The patient could be developed a lot of abnormal vital signs or hypotension because of high P. Could be anxiety, stress, sleep deprivation. could be ulcer, gastritis, and malnutrition. Increase in intrathoracic pressure leading to the systemic problem like, again, decrease in cardiac output and hypotension, edema due to decrease in venous return. Okay? Let us go for the first important complications, valve. Number one, oral intubation is peripheral than nasal. We are not recommended to make nasal because nasal, again, could be make more an infection. Oral is more actually preferable to intubate the patient by ETT. Avoid disconnecting the patient from the ventilator. Anytime it's disconnecting, the pressure and the PEEP will be decreased. Lead to what? Anaphylactic. Don't disconnect. If it's suddenly, you need to be very careful, be sure you are connect direct, and examine the patient after that is must. Keep patient semi-command position, 35 to 45 degree, when it's not prone position. If the patient is not in prone position, you need to keep the patient 35, 45. This is one management or nursing intervention to prevent valve. Remember here, the sitting position also it's important for the patient with head injury. Not only for the ventilation valve. And the head injury actually, because when you keep the patient lie, actually it's increasing in ICP. You need to keep all the time head injury, keep the patient for 45 degrees. This is one intervention also to minimize or to maintain ICP around the normal level. If the patient is not prone, but sometimes, anytime we can keep the patient with 45 degrees or no. What do you think? Ventilated patient. Anytime, any case, or there is some contraindications? There is some contraindications all the time. One of the most important is what? Spinal cord injury. Spinal cord. Sometimes here it's not allowed for you. You can put the patient all as reverse, the bed, but don't keep the patient alone for 45 degrees because maybe the patient with discectomy, for example, we can't keep them like that. Spinal cord injury, don't. All the time be careful and ask, is it possible that okay, على طول we are keeping the patient 45 degrees, maybe lead to complications, okay? But sometimes, most of the time, we need the patient in the ICU 45 degrees to prevent valve. Patient head injury, keep 45 degrees. Spinal cord injury, discectomy, and other back surgery, be careful. There is something I would like just to go back because in the be sure and be careful. For the COVID patient, we are transfer a lot of blood transfusion. So many, through a huge amount. All the time, please, and please again, check the vital signs. Check the vital signs, number one. Number two, check if the patient has renal disease or no. Must. Check the patient, he is heart failure or no. Overload, somebody asked here a question for the Resix. It's a good question. Because we are given furosemide mainly for the elderly, mainly with heart failure. Because we need to, if you give like that, if you give too much fluid for the elderly, they will not tolerate. Heart failure, it will come and it will make a problem for the patients. But be careful for that. Be careful, check the contraindication when you give over fluid. I think my colleagues mentioned something regarding to give fluid normal saline with order. Remember, don't flush even 1 ml more. Don't. Why? The idea is if the patient is renal failure, he can't expel urine out. That 1 cc or 10 cc, the problem when you give with normal saline, how to release from the renal patient, for example, very difficult. Be careful for that one. The issue with the ventilated associated pneumonia, all the time, the mortality and the cost, the morbidity. The idea is the patient, they will stay a long time with the hospital. Why we are taking too much care to prevent pressure injury, to prevent valve, to prevent infection? This is cost. Who will pay? And the patient mortality rate also, it's high. Length of stay in the ICU and cost. This is very important here. Nowadays we have a global crisis, financial. To keep the patient to stay for a long time, look just for the stuff, for the medication, for the longer we stay, who will pay. We have so many things. Okay? Next. To prevent shield valve, remember we prevent shield valve just to be in the same. Number one is what? Oral intubation, peripheral with the amnesic. Number two, avoid disconnection. Number three, keep 45 degrees. Number four, perform regular oral care with chloroxylamine, mouthwash, oral gel is preferred. What is the last? Chloroxylamine, oral wash, but it's not continuous. Before they mentioned last year, it's every 2 hours you can do chloroxylamine. Nowadays, no need for that. But at least within 4 to 6 hours, 8 hours, we can do at least once. But you need mouth care every 2 hours, even with water. Even water, it's fine. Okay? Water, I mean the tap water is fine. Not from the sink, but I mean even the water for the patient, it's good. Normal saline, it's not preferable too much because it's the normal saline we have salt. And that salt leads to more dry for the patient mouth. That water is important with the chloroxylamine. If here I think they are using, every 8 hours, they are doing the chloroxylamine mouthwash, okay? In other change, the heat moisture exchange, when malfunction soil every 5 to 7 days, that the moisture and the heated that with the circuits, you need to be very careful and follow the hospital policy. Consider specialized endotracheal tube with what? Subglottic suction. The idea here, this is the, I told yesterday, the good nerves, they will select this one. Nowadays we have the subglottic ET tube. This is endotracheal tube. This is the balloon, okay? And this is around 2 centimeters above the carina to give the right side and the left. Mainly within few years, just newly, they discovered something is very, very important. Yes, we are doing the suctioning from here, from the lung, but we have a lot of accumulation of secretions here, above the cuff. Lead to, this is the major cause of the ventilated associated pneumonia. According to that now, we have the subglottic suctioning. We are put the catheter here, the suction here, and we are making the suction from here to remove this. This is essential. Again, essential to protect the valve. Other things is very, very important all the time. Be sure that the cuff is inflated. Okay? And be sure we are doing closed suctioning system, not open suction system. You understand? The open, before we are opening sterile gloves, disconnect the mechanical ventilator and make open suction. The problem with the open suction, that time we need to disconnect. After that, they will start to open suction from here. And this is a source of contamination and source of infection for those patients. Okay? Nowadays we have, you know what does it mean? Does it mean by closed system? Closed. Just by plastic. Okay? And everything is covered. And we are doing that in very, very properly. The question for you, where is the ICU nurses? Disappear to the they go outside. Okay. I am inserting the catheter for suctioning. Okay? We will talk about it later. How long I will insert my catheter inside the lung? How many centimeters will you know?
19.
No, I'm not talking about the length of the ET tube. ET tube here should be 21 or 20. That's it. It's fine. But when I put my suction here, for how long I will keep it inside the lung? 10 centimeters long, 1 centimeter, 5 centimeters. What do you think? 5 to 6 centimeters.
Hindi naman, napakaliit naman.
What do you think, guys? Sure, is it?
As long as open yung ano, na free kang makapasok sa loob.
Is it too much difficult, yani?
Ikaw, te.
Okay. Because I think we are more in the hospital and we know a little more and we are updating all the time. And we see some traumatic injury when we are doing suctioning for the patient. Traumatic injury, and we can see if there is blood in the bottle. Two things all the time. We have, number one, we have high pressure, and all the time we have what? We have suctioning, traumatic suctioning.
Pag hindi mo
Now,
ang
what is the
nagsusuction.
correct concept? And this is from the
Pag
American Critical
pinupok
Care
mo,
Association.
kailangan open.
The most important, we are making suctioning for the tube, not for the lung. Yani don't insert in the lung inside, don't. Okay? We can insert from the tip maybe little. 1 centimeter is accepted. Rather than that, no, don't. Even for the trachea, I'm making only for the trachea, the suctioning. Not going inside the trachea half meter because we make injury and make a problem for those patients. Okay? In non-COVID patients, the normal patients, we have another thing is important for us. Sometimes the doctor, they would like, please, Mr. Imad, deflate the cuff. Deflate. Is it important? Is it good practice or no? What do you think?
But practically, sometimes the doctor ordered for the deflate and then do suction and then again deflate.
Yeah, could be, but my question is it good practice to deflate the balloon or no? No. Sometimes you are not thinking, I think. You are just saying no, yes, yes, no. In fact, sometimes, again, with non-COVID, because the rationale behind we're keeping that one inflated, number one is the placement of the tube, number two, to prevent aspiration, okay? The aspiration coming from the, again, from here, from the esophagus, to go back to the lung. When it's deflated, it will be accumulated here. It's fine. And by suctioning, we can remove it.